So Carl, now let's shift back to stage 3. So what do you do at this point?
So this is just a sort of a spoiler alert. This is controversial.
No,
Right?
no, we haven't got to the controversial stuff yet. It's 2B2C. It's even more controversial.
Stage 3 is controversial. So depends. So when you say stage 3, these are patients who have generally metastatic disease to regional lymph nodes and are potentially resectable. Right?
Yeah.
So the question is, how do we do this? Now, this treatment paradigm has been changing rapidly over the last 2 or 3 years. In the olden days, that is to say, 5 years ago, the treatment would be surgery. The first treatment would be surgery. They have,
You mean you're talking about the complete lymph node?
correct. Or you have a patient who's recurred in a lymph node area, right? We would do surgery to render them free of disease, and then discuss adjuvant treatment. Back in the 90s and the 2000s, the only adjuvant treatment was interferon, which some people used. So now there are data for adjuvant use of ipilimumab, adjuvant anti-PD-1, mostly pembrolizumab, and in BRAF mutated patients, adjuvant dabrafenib and trametinib,
which is the targeted therapy. Okay, go ahead.
Target therapy. And so there's data for all of these. They're all FDA approved.
Yeah.
So this is a discussion we have with our patients who come to us after surgical resection about whether or not to have adjuvant therapy. It's a complicated discussion because of the deficiency in the data, right? It's clear that any of these adjuvant treatments will decrease the risk of relapse. How much does it decrease the risk of relapse? About 20%. So if your risk of relapse is 60%, then with treatment, we can decrease that to about 40%, as for an example. What we don't have is good data to show that we've actually improved survival.
Yeah.
Because the alternative is to treat you if you recur, right? So this is where we're getting into the weeds, but the weeds are sort of important. The original adjuvant trial was using ipilimumab, and in that trial, which showed an improvement in relapse-free survival, it also showed an improvement in overall survival. So that's great. Except when you start looking at the details, you find that most of the patients who were randomized to observation and who relapsed, most of those patients were not treated. Why were they not treated? Because in most of the countries where this trial was done, ipilimumab had not been approved yet. It was
wow.
So IPI was not an option for these patients, and the trial didn't have a crossover part. So yes, that trial showed improvement in overall survival, but it didn't really ask the question we want to ask. What it asked was, is IPI better than nothing? So we already know the answer to that. It is better than nothing. What we really want to know is IPI now better than just waiting and giving it later if you need it? And that trial didn't answer that. And the only trial that's addressed that is the adjuvant pembrolizumab trial, where patients were randomized to pembro or placebo in the adjuvant setting. And if you recurred, you crossed over. So if you were in the placebo arm, you recurred, you got pembrolizumab at the time of relapse. That trial is now pretty mature with 5-year follow-up at this point. And this trial again showed treatment improved relapse-free survival by about 20%, but they have yet to report any overall survival difference.
So the idea is if that readout of the data come out and show that there's no overall survival benefit, and the temptation is let's not pre-treat those individuals for the adjuvant prophylactic progression-free.
Because you're exposing so many patients to toxicity, right? So if you've got a patient with a 40% chance of being cured after surgery, you're going to really put them on a year of pembrolizumab and risk them having hypothyroidism or type 1 diabetes, which is not reversible, right?
And then not to mention some of the earlier, more life-threatening complications like
so
colitis. Yeah.
Whereas if you have metastatic melanoma and you treat them and the tumors shrink and they have one of the side effects, well, that's a pretty good trade-off, right?
Yeah.
But so we have this very detailed discussion with patients about adjuvant therapy, about the risks and the benefits. Benefits being a decreased risk of relapse, but no evidence of survival benefit, versus the risk, which is to say the toxicities. And when we have these detailed discussions with them, and actually going over what the risks of the toxicity are, in our experience, a little more than half of the patients opt for observation.
No, that's important. I mean, also depending on who's sitting in front of you, right? And then like the way there may be another oncologist who is really more aggressive and who felt that this needs to be pre-treated, and that discussion, the nuance, the tone will sort of guide that patient in towards the adjuvant, right?
Absolutely. And so we think that's sort of unfair. I think we really, if we're going to talk to the patients about this, we have to be truthful about what the benefits are and what the risks are. And if you go through all that and the patient says, yeah, I still want it, then we give it to them.
So I guess we only have 5 minutes left. And so since this is your feeling on stage 3, I guess for stage 2B and 2C, you are even more.
Yeah, for stage 2, we don't even talk about it.
Okay. Even though there's an indication for adjuvant, but for that, I think you're looking at the benefit risk reward. You say like,
it's approved for stage 2, but if you look at that paper, it's clear. I mean, you start doing the arithmetic, they clearly hurt more patients than they help. So what I do for stage 2 is I tell patients, listen, this is FDA approved for stage 2, but I don't recommend it. Because I know I wouldn't take it if I were a patient.
No, I mean, I think this is the most important line, right? And I think at the end of the day, patient will, like, you can give them all the statistics and all the papers and all the like number needs to treat, the side benefit, and they're just gonna look at you and say, what would you do, right? And so I mean, I think when
patients ask me, I said, well, if it were me, I wouldn't do it.
Yeah. But likewise, there will be the other docs, some other docs, they will look at the data, they'll be like, hey, I will do it, right? And I think that's it's kind of a judgment call, but you have like decades and decades of experience looking at this, and then also on top of which, I guess as the year comes along and we have more data coming out, and that we will know a lot more about, what is the right choice.
Yeah, I think when the pembrolizumab trial, if they report out their survival, then we'll know, right?
Yeah.
Survival, good.
Because at the end of the day, it's not progression-free survival, it's the overall survival.
The whole point of adjuvant treatment is that we are more the assumption is we're more likely to cure you if we treat you in the adjuvant setting. That's the question. So so the question is that true or not?
Yeah, I mean, those are not easy drug that you take without the side effects, right? We talked about those 2 life-threatening ones, but you also mentioned this chronic stuff like diabetes and hypothyroid and and not to mention like arthritis and all of that stuff.
Yeah,
And it's not
yeah.
easy.
Not easy, yeah.
Paul,